As more than 70% of errors can be attributed to human factors rather than knowledge or skills gaps, the following recorded scenario aims to highlight both the technical and non-technical aspects of team resuscitation. The resuscitation team you will see uses the current New Zealand Resuscitation Council algorithm, following a DRS ABCD approach. It's important to minimise the time not doing effective chest compressions when they're required, to use the defibrillator safely, and to check drug doses carefully. Non-technical skills include communication and teamwork behaviours that help to lead an efficient and successful team. Such behaviours include clear role allocation by a hands-off leader, an early call for help, information sharing. The leader recaps the situation, creating a shared mental model, and invites team input. Using a cognitive aid such as the resuscitation algorithm to ensure that the team is on task, moving forward and not forgetting key points. Specific, directed, clear, closed-loop communication between team members. The ISBA tool for handover of information. Identify yourself, state the situation, give background, state your assessment, and give or ask for recommendations. Constructive intervention by team members if something needs correcting. Active fellowship by all team members. Feedback to leader regarding tasks and provide suggestions if able. Don't be afraid to speak up. Mutual respect, acknowledgement of people's strengths and weaknesses, allowing appropriate role allocation. Watch how the following team uses these tools and behaviours in a resuscitation setting.
Hi, Mr. Amara. My name's Olivia. I'm one of the nurses. How are you feeling?
No, not so good.
Oh, what's wrong?
Oh, my chest is sore.
You have pain in your chest?
Yeah, it feels really tight.
Oh, how long's that been going on for?
Oh, it's been about 10 minutes.
Have you had this before? Mr. Amara, have you... Mr. Amara? Mr. Amara? Hi Brenda, he had chest pain and then collapsed. He has no pulse, so I think we should put on the AED and see if he's in a shockable rhythm.
Okay.
He's 2 days post hip joint replacement. I'll keep going.
Switch it on to AED.
Great.
Analysing.
Shock advised.
Shock advised, Olivia. Charging.
Stand clear.
Stand clear.
Press shock.
Shock delivered.
Shock delivered.
You know when you get to 30, Olivia.
Okay. 28, 29, 30.
2 breaths in.
Hi guys. Can I have someone to take over chest compressions? Dave?
Sure, I will.
Chest patient.
It's up to 5.
Pulse. Press
So this guy had chest pain and then collapsed. He had no pulse, so we've started CPR. He has had 1 shock with the AED. He is 2 days post a hip joint replacement. We need a leader.
Okay. My name's Ben. I'm one of the house officers. I can lead if you like.
Okay.
Now, have you made an arrest call?
No, I can do that now.
Okay, great. Robin, could I ask you to take over the airway, please?
Yes, Ben.
Abby, could I ask you to draw up medication?
I'm not very comfortable drawing up medications. Maybe one of the nurses could do it.
So I can draw up the drugs, adrenaline and amiodarone. Abby, if you want to take the defib
Sure,
and
yeah.
do the timing, I can do the adrenaline and amiodarone.
Sounds great.
Okay. Cool. So Ben, I'll just turn it to manual mode now, and then I'll let you know when we're coming up to 2 minutes.
Thank you. I have a good airway, Ben.
Great. Thanks, Robin.
I've made the arrest call, Ben.
Great.
Mr. Amara is 2 days post hip joint replacement. It's been an uneventful admission so far. He's got high blood pressure but no cardiac history. Just hypertension, and he had chest pain and then collapsed. I wondered if it was a PE.
Right. Any new medications today?
No.
No. And any bleeding?
No, his wound was all clear.
And what is his blood test like today?
Let me check.
Okay, so we're coming up to 2 minutes now, guys. I'll start charging. Keep with the compressions, Dave. Charging now. Okay, everybody stand clear, standing clear. So we're still in VF, delivering shock now. Shock delivered.
We should give 1 milligram of adrenaline now, right?
Thanks. Give it now, Brenda.
That's 1 milligram in. And flushing. Adrenaline flush.
Great.
His bloods were all normal today, Ben.
Okay, great.
Okay, Ben.
Thank you. Robin, could I get you to go a little bit deeper and faster, 100 per minute?
Yes, Ben, I can do that.
And can you swap with Dave at the next shock?
I will do that.
Okay, so this is a VF arrest. We've called an arrest call. We've done 2 shocks and 1 dose of adrenaline. We think this might be a myocardial infarction or perhaps a pulmonary embolus. And we're going to need to give amiodarone next. Does anyone have any other ideas or think that we're missing anything?
I think that sounds reasonable.
Sounds good.
No.
I don't think we're missing anything.
Okay, so we're coming up to 4 minutes now, guys. I'll start charging. Keep on with the compressions, Robin.
Okay.
So charging now. Let's charge. Everybody stand clear. Stand clear. Still in VF, delivering shock. Shock delivered.
Okay, 300 milligrams of amiodarone should be given next.
I've got 300 of amiodarone here.
Thanks, give it now, Brenda.
Giving 300 of amiodarone. And flushing.
Thanks, keep going everyone. Olivia, can you go through the H's and T's with me?
Yep.
Okay, so hypoxia. We have a good airway
Yes.
and we're giving oxygen.
Yes.
Great, thank you. Hypovolemia, we don't think there's been any bleeding.
No.
Does anyone else think that we're likely to be hypovolemic?
No.
Okay, hypokalemia, we're going to need to get some blood tests soon.
Okay, but they were normal this morning.
Has this patient been really hot or really cold?
No.
Okay. Tension pneumothorax. Robin, could I ask you to listen for a pneumothorax, please?
Yes, I'll have a listen.
Okay, and tamponade, has anyone seen dilated veins?
No, his neck veins were looking normal when I came in.
Okay, toxins, he hasn't been on any new medications. And thrombosis, I think thrombosis is most likely, isn't it? We think this is a pulmonary embolus or perhaps a myocardial infarction.
Entry is bilateral and normal.
Olivia, could I get you to take bloods? The priority would be to get an urgent blood gas.
Okay, and you'll do documentation?
I'll do documentation, thank you.
Okay, guys, we're coming up to 6 minutes now. I'm going to start charging. Dave, you keep doing compressions. So we're charging now. Okay, charged. Everybody stand clear. Everybody clear. Still in VF, delivering shock. Shock delivered.
Okay, adrenaline's next, Brenda.
Almost ready.
Great.
Ben, patient just started groaning now.
And his eyes have opened as well.
Great, stop compressions. Abby, could I get you to continue to watch the rhythm?
Sure, we've got sinus tachycardia at the moment at just over 100.
Terrific. Could I get you to continue to watch that and also to measure blood pressure and obs for us?
Sure.
And Dave, could you continue to watch the airway?
Sure.
Great.
I'll get the ECG machine. The arrest team will want a 12 lead.
Okay, terrific. And Brenda, could I get you to chase that blood gas we asked for?
Okay.
Hi, I'm Jane. I'm the CNA. Just carry on, guys. Hi.
Hi, my name's Ben. I'm the house officer on the ward.
Yeah.
This man has had a VF arrest. He's been shocked and we've had a return of circulation.
Great. Okay.
He was admitted to hospital 2 days ago and has had a hip operation. Seemed well this morning and he was witnessed by Olivia to complain of chest pain and then collapsed.
Yes.
He had VF and he's had 4 shocks.
Yes.
And 1 dose of adrenaline and 1 of amiodarone.
Great. Okay.
And we're now just supporting his breathing.
So what do you think it is?
Look, I think it's most likely that this is a pulmonary embolus or a myocardial infarction.
Yep, sounds like it.
We think we've ruled out a tension pneumothorax. We've sent for bloods, which aren't back yet, and we haven't noticed any signs of bleeding.
Okay, great. I think you should probably have some fluids up as a next step. Is someone free to do that? Abby, could you do that, please? Put up a bag of plasma light to run through fast.
Sure, I can do that.